Good morning, everyone. I'm Dr. Akash. Good morning, everyone. Nice to start.
Yes, हमने ठीक है, रुक जाइए arrest है
Good morning, everyone. I'm Dr. Akash Pandita. Today we'll be discussing about CPAP and surfactant. In next 15 to 20 minutes, we'll discuss about what is CPAP, how does it work, when should we consider giving surfactant. We'll also discuss some of the evidence behind the use of CPAP and surfactant, and some practical issues with the CPAP use. Before we move further, we should know what is respiratory distress in a newborn. If baby has tachypnea, retractions, grunt, or nasal flaring, out of these four signs, at least there should be two signs present to label a baby having respiratory distress. And it's also important that certain basic principles should be kept in mind for managing preterm babies with respiratory distress along with the CPAP. These includes use of antenatal steroids for all mothers who are going to deliver before 34 weeks, use of a blender for delivering oxygen, and always use a pulse oximetry whenever a baby is on any form of oxygen, including CPAP. CPAP affects what basically the CPAP. What happens with the CPAP is it delivers a constant descending pressure, which recruits the alveoli, thereby establishing FRC, improving.
तो बैटरी लो हो गई सर वो पता स्टॉप में हो गया बंद
Maybe say, वहीं से starting से करेंगे. मैं ठीक है, ready? Good morning, everyone. I'm Dr. Akash Pandita from Medanta, Lucknow. In this webinar, we'll be discussing about CPAP and surfactant use in newborns. We'll be discussing about surfactant, use of CPAP, some of the evidence behind the use of CPAP and surfactant, and finally, some of the complications related to CPAP and how we can prevent them. Before starting the main subject, we should also know what is respiratory distress in a newborn. If baby has tachypnea, retractions, nasal flaring, or a grunt, out of these four signs, presence of only two of the signs qualifies a baby for having respiratory distress. The basic principles which we should consider while managing babies with respiratory distress is that all mothers who are going to deliver before 34 weeks should receive antenatal corticosteroids. All babies on oxygen should have a pulse oximeter attached to the right upper hand. They should be given oxygen only with the use of blender, and all babies, preterm babies, should be screened for ROP. Coming to the main topic, how does the CPAP act? CPAP establishes FRC by providing constant descending pressure. Once the alveoli are recruited, there is improvement in the ventilation perfusion and decrease in the ventilation perfusion mismatch. This improves oxygenation, causes CO2 washout. Also, in preterm babies, the airways are very pliable because of the less cartilaginous tissue and less muscle mass, leading to collapse of the airways. By splinting open the airways, the CPAP prevents obstructive apnea, and by stretching the lungs, thereby stimulating the J receptors, it also helps in central apnea. But one thing to remember is whenever we are managing a case of apnea, the caffeine remains the drug of the choice. So both caffeine and CPAP work hand in hand. Whenever we are giving CPAP, it is important to give optimal pressures. Pressures too low or too high both can be detrimental. If we give too low pressures, then the lung will not be properly recruited and there will hardly be any gain in the volume. And if we give too much of high pressures, there can be raised intrathoracic pressure, leading to decreased cardiac out and shock. Also, the pulmonary vascular resistance has a U-shaped curve with respect to the lung expansion. That means if the lungs are either less expanded or overexpanded, the peripheral vascular resistance is going to increase, thereby preventing blood supply to the lungs and causing hypoxia, thus initiating a vicious circle of hypoxemia and acidosis. So the normal pressures in clinical practice range from 4 to 8 centimeters of water. Now consider the ventilation whenever we compare the CPAP with mechanical ventilation. CPAP reduces death. It also reduces BPD. and it also decreases the need for ventilation and surfactant by almost 50%. The most common indication of CPAP is any preterm baby having respiratory distress, the most common cause being respiratory distress syndrome. It can also be used in term babies who have moderate to severe respiratory distress like meconium aspiration syndrome, MAS, or pneumonia or any other lung condition. It is also important therapy for post-extubation, especially for premature babies and VLBW babies. As already discussed, it is also useful both in obstructive as well as central apnea. However, one should always remember that for putting a baby on CPAP, or for that matter, any non-invasive respiratory support, baby should have good spontaneous respiratory efforts. Coming to the settings, the main setting is the CPAP pressure, which is again range between 4 to 8. If the lung conditions are normal, like in apnea, we start with lower pressures, whereas in lung conditions like RDS or meconium aspiration, we start with pressures of 5 to 6. Then we have FiO2 to deliver oxygen anywhere between 21 to 100% with the saturation target of 91 to 95%. Then we have flow in bubble CPAP. The flow should be anywhere between 4 to 6, and there should always be a continuous bubbling. The minimum flow at which we get a continuous bubbling is the adequate flow, and it should not be changed once we have set it. Then two other knobs which are very important and often neglected are humidification and temperature. All gases which are given to the baby should have 100% relative humidity, and temperature should be 36.5 to 37 for all non-invasive and invasive modes of ventilation. Now, when should we see that the pressures which we have set are adequate? The retraction should subside. There should be minimal or no retraction. X-ray should show well lung expansion, that is 6 to 8 spaces, and baby should have a normal saturation. For FiO2, it's very easy bedside test. That is, the saturation should range from 91 to 95%. And in blood gas, we should have a normal PO2 between 50 to 17 preterm and 50 to 18 term babies. Flow ventilator, it is automatically usually around 8 to 10 liters. In bubble CPAP, there should be continuous gentle bubbling. Humidification, there should not be any condensation in the inspiratory limb. There can be some condensation in the expiratory limb. And temperature should always display 36.5. Ideal CPAP settings are when baby is comfortable, baby is pink, there are no retractions, blood gas is normal, abdomen is soft, and saturation is between 90 to 95. So this is the normal CPAP assembly, which has the air oxygen mixture going into the blender, where the gases are humidified and vomidified, goes to the baby with the help of interface, and then comes back. And in case of bubble CPAP, this pressure is generated by immersing the expiratory limb in the water, whereas in the ventilator, it is delivered by the PEEP valve. Now, CPAP can be delivered either through ventilator, that is ventilator CPAP, or bubble CPAP, or infant flow driver. That is, one are fixed flow devices, other are variable flow devices. But although there is some difference in theory, but when we consider the harder outcomes like incidence of BPT, mortality, there is no difference either whenever you are using bubble CPAP, ventilator CPAP, or variable flow device, which is also known as infant flow driver. All are same. The advantage with the bubble CPAP, although again it is a theoretical advantages, it also with the bubbles it generates oscillations just like HFO, which may help in improvement in the oxygenation, but the evidence is not very hard. The interfaces which are commonly used are the short binasal prongs or mask. The advantage of the mask is that it causes less nasal trauma. Since babies are obligate nasal breathers, it does not cause the decrease in diameter of the nares. In RDS, we usually start with a setting of 3, 4, 5. That is FiO2 of 30%, flow of 4, and CPAP pressures of 5. And then depending on whether there are not retractions or not, we escalate the pressures. Saturation, FiO2 is kept as per the desired saturation. And all babies who are less than 32 weeks should receive caffeine if they are requiring oxygen support. It's also important to remember that all preterm babies should receive delivery room CPAP, that is given with the help of the TPs. CPAP can also be used in meconium aspiration syndrome, but the pressures are usually kept between 5 to 6, especially when there is secondary surfactant deficiency with a low volume lung picture. We should consider surfactant in meconium aspiration if the FiO2 is more than 50%. for 2 or more hours. In apnea, since the lungs are normal, we use lower settings, pressures of 4 to 5. And again, FiO2 is usually kept between 20 to 30% to get the desired saturation. Remember, the drug of choice for apnea is caffeine. Post-extubation for all VLBW babies are put on CPAP with pressures of 5 to 6, FiO2 similar to the ventilation. Now coming to the surfactant therapy is usually given by two methods. One is ensure that it intubate, give surfactant, extubate CPAP. But again, for that method, we have to put a tube across. The newer technique, which we are called is sure, that is surfactant without intubation. It is also known as Rees or Mist. We have published various publications. This is the largest RCT which we published, and we showed that with this technique, we can decrease the incidence of mechanical ventilation as well as BPD. Now in Lisa, why it is important, why Lisa is more promising. First of all, in Ensure, whenever we used to do Ensure, we used to remove the CPAP. So whatever FRC we had achieved, that is lost and leading to atlectotrauma. Second, we used to intubate, that causes biotrauma. Then we used to bag, which causes barotrauma. And then these babies used to be put on ventilator, which again causes volume trauma. Whereas in the Lisa, the babies are kept on CPAP, so FRC is established. Then we do not put a AT2, so biotrauma is not there. We do not bag, so there is no barotrauma. We do not put babies on ventilators, so there is no volume trauma. In addition, babies breathe spontaneously, which leads to better distribution of the surfactant. Now coming to the weaning from the CPAP, there are two methods. Either pressure weaning, where we decrease the pressures gradually, and once we are on pressures of 4 to 5 or 5 to less than 30, we wean off. The other is called the cyclic weaning, where we give the off time from the CPAP. That is, we remove the CPAP for a few hours, and this duration is gradually increased. When we compare these two methods, the gradual pressure, where we decrease the pressures gradually, is more beneficial. It decreases the duration of hospital stay and duration of oxygen. So pressure weaning is the preferred one. Now, one should we consider failure of CPAP. If the baby is not maintaining saturation despite giving pressures of 8 to 10, FiO2 of 50 to 60, despite giving surfactant, baby continues to deteriorate, then we should consider CPAP failure. Remember that the prong should be snugly fixed, gases should be adequately humidified. We should have consider giving surfactant before jumping to higher modes of ventilation. Now, the complications with the CPAP are, they are usually related to the interface, that is, the nasal injury is the most common. Then all babies who receive oxygen, whether it is CPAP or any other mode, should have an OG in place so that whatever gas is going to the stomach, they are went off. Otherwise, it causes an abdominal distension, which is also known as CPAP belly. Then, if we give high pressures, as already discussed, there can be increased intrathoracic pressure leading to decreased cardiac output. Now, then always maintain asepsis, do proper hand wash, do clustering of procedures, use disposable wherever possible, and ensure a good nutrition for babies on CPAP. Remember, CPAP is not a contraindication to feeding. Babies can be on full feeds despite being on CPAP or, for that matter, ventilation. Counseling is very important for patient. They should know whatever their baby is getting, how the baby is progressing. Should always counsel the parents and take time to counsel properly. Always document well, monitor these babies well. Always take a consent for CPAP. Baby should always be nursed in developmentally supportive care with minimal lighting, minimal sound. They should always receive KMC wherever they are stable, and they should always receive pain management. So this is the monitoring chart for CPAP, where we should have a monitoring charts, and baby should be monitored every 2 to 4 hourly, depending on how sick the patient is. This includes heart rate, respiratory rate, SAS score, which is a score used to monitor respiratory distress, which is based on upper chest, lower chest traction, xiphoid tractions, grunt and nasal flaring. And then we have CRT, CPAP pressure, saturation, FiO2 flow, and abdominal girth. So in nutshell, this is the algorithm for the respiratory management. For all preterm babies who have respiratory distress, CPAP remains the mode of choice. If the babies fail CPAP, then we should consider NIV before jumping to the mechanical ventilation. For post-extubation, CPAP, NIV, HFNC are all equal, whereas we prefer NIV in babies who are less than 28 weeks, both as a primary mode and post-extubation. For bigger babies who are more than 32 weeks, HFNC can be considered as primary mode if the distress is not severe. So my take-home messages are that CPAP is the backbone of the respiratory care in neonates. CPAP is not only safe, but it is also effective. Surfactant should always be considered in babies with respiratory distress. Whenever their FR2 goes more than 30%, we can give 2 to 3 doses. Then complications are there, but with the good nursing care, the majority can be avoided. Patient counseling is must and should always be done. Thank you and have a great day.